So it was a 34-year-old female from Bathinda. She complained of profuse watering and sudden diminution of vision in left eye since one day, and then had blunt trauma uh, previously on that day itself. She also had mild pain. She was a known case of bilateral pigmentary glaucoma, had bilateral cataract surgery and bilateral trabeculectomy in the past. The findings of the right eye were normal. In the left eye, the patient presented with hand movements vision, and the eye was very soft to touch. The intraocular pressure on examination was 4 mmHg, and anterior chamber was flat. And obviously, the pupil was fixed dilated. Sorry. On presentation, this is the clinical picture of the patient, which showed that the patient had ruptured blebs at the superior limbus, also had a flat anterior chamber, had a fixed dilated pupil. This is the anterior segment OCT of the same picture, in which the transscleral fistula can be seen, through which whole of the aqueous was draining out. Sedals of the patient was positive, the anterior chamber was flat, and there was a iridocorneal touch. On posterior segment examination, the choroidals were present. So how did we manage it? We did a left eye scleral patch graft with conjunctival advancement, in which the bandage lens was applied post-operatively along with antibiotic and steroid coverage, topical. Also, cycloplegic drugs were given, and systemic antibiotic cover was also given to the patient. After 15 days of follow-up, patient presented with very low IOP and sedals was slightly positive. So we applied cyanoacrylate glue at the site of scleral patch grafting to maintain the anterior chamber, as the anterior chamber was well formed at this presentation, as we can see in the picture. 3 months post-operatively, status post-glue removal. This was the picture of the patient. The anterior chamber was well formed and intraocular pressure was maintained at 9. So this is the picture 3 months post-operatively. The patient had a good vision, 6/9 she was maintaining, and she did not have any complaints as such. So what we conclude out of this is that scleral patch graft with conjunctival advancement was the definitive management to be done for bleb leak due to scleral fistula, averting potential catastrophic consequences. It not only restores the ocular integrity but also visually rehabilitates the eye. The patient now needs regular monitoring for wound leaks, IOP spikes, and may need glaucoma filtration surgery in the future. Thank you so much.
Supreet, glue rather than applying a patch, a scleral patch, because there is a potential risk of rejection of scleral patch.
So, sir, there was a perforation present, which was quite, it was not a small one. It was around 2 to 3 mm. Basically, the bleb was ruptured. So, we preferred applying a patch rather than the glue straight away.
Okay.
Is there any guideline when to use patch graft, when to use glue?
Yes, ma'am. It depends on the size of the perforation.
What is that?
It is, ma'am, 2 mm. If it is more than that, then 3 mm. If it is more than that, then we need to do the patch grafting.